Welcome to the Australian Dental Council Explainer podcast.
Glad to be here, diving into this one.
Yeah, and before we get started, I just need to state that this content is purely educational and not a commercial endorsement.
Right, absolutely. Just keeping it to the science.
Exactly.
Yeah.
So, we spent all these years in dental school mastering, like, the perfect cavity preparation.
Oh, yeah. The perfect tiny little box.
Right. We learned to isolate a tooth, mix the composite, sculpt the anatomy down to the absolute micron in that controlled, well-lit little box of the oral cavity. Dentistry feels like predictable engineering.
It really does, until it doesn't.
Exactly. Because then you graduate, you're in the clinic on a random Tuesday, the burr's in your hand, and suddenly the patient stops breathing.
Or they start seizing in the chair.
Yeah, or that slippery upper molar root tip just vanishes into the maxillary sinus with this sickening little pop sound.
The worst sound in the world.
It is. And suddenly, that predictable engineering world just shatters, and you are plunged into the murky, chaotic, high-stakes reality of human biology.
Which is exactly what we are focusing on today.
Right. Today, we are speaking directly to you, the overseas-trained dentists, the ADC candidates, dental students, and Australian oral health therapists.
It's a huge topic.
It really is. Our mission for this deep dive is to synthesize high-yield clinical reasoning skills directly from Odell's clinical problem-solving in dentistry, specifically looking at the 4th and 5th editions.
Such a vital text, by the way.
Oh, completely. We're pairing that with the standard ADC communication cast scenarios.
Yeah, Odell is brilliant because it bridges that massive gulf between, the theoretical oral biology you memorize for written exams and the totally unpredictable realities of actual patient care.
Right.
We're looking at the evidence-based frameworks for medical emergencies, special needs patient management, oral pathology, and the highly nuanced communication required when surgical complications inevitably happen.
Okay, let's unpack this by starting where control is lost, the fastest acute medical emergencies.
Makes sense. Seconds count here.
Exactly. We're starting here because a practitioner's diagnostic rigor is tested the most when seconds count and adrenaline is just spiking. Odell highlights this beautifully in case 13, which is about a sudden collapse in the chair.
Just going totally unresponsive.
Yeah, patient just goes down. How do we rapidly distinguish the underlying physiology between, say, a simple vasovagal syncope, a full-blown cardiac event, and anaphylaxis?
Well, it requires shutting out the panic entirely and just focusing on physiological patterns. Like a vasovagal syncope, a common faint, is driven by the vagus nerve.
Right, so blood pressure just drops.
Exactly. The patient experiences a sudden drop in vascular resistance, leading to cerebral hypoxia. But the key is there's usually a prodrome. They look pale, they feel hot or dizzy, and crucially, if you check their pulse, you'll find bradycardia.
A slowed heart rate.
Right. Contrast that mechanism with a cardiac event. The myocardium is physically starved of oxygen. You might see the classic Levine sign where they clutch their chest, pain radiating down the left arm or up into the mandible, and dangerous arrhythmias.
And then there's anaphylaxis, which is an entirely different beast.
Oh, totally different.
It's an acute IgE-mediated multi-system allergic reaction. Mast cells essentially detonate throughout the body, releasing just massive amounts of histamine.
And that massive histamine release is what causes the profound vasodilation. The blood pressure just tanks, often accompanied by compensatory tachycardia as the heart desperately tries to keep up.
Because there's suddenly no pressure in the system.
Exactly. You are looking for a sudden onset of skin changes, like urticaria or severe flushing, coupled with dangerous respiratory distress as the histamine causes brutal bronchospasm.
And the response to that bronchospasm and vasodilation is what Odell really zeroes in on for case 37. It is all about the immediate administration of intramuscular adrenaline or epinephrine.
Yes.
But the sources are incredibly rigid about the concentration here. It must be 1 milligram in 1 milliliter.
The rationale behind that specific concentration is literally a matter of life and death. The 1 milligram in 1 milliliter ampoule is formulated strictly for intramuscular injection, typically into the highly vascular anterolateral thigh.
Right.
Adrenaline works by binding to alpha-1 receptors to violently constrict those dilated blood vessels and push blood pressure back up, while simultaneously hitting beta-2 receptors in the lungs to force the airways open.
So what happens if you grab the wrong one?
Well, if you mistakenly administer the intravenous concentration, which is much more dilute at 1 in 10,000, or, God forbid, give the IM dose intravenously, the sudden surge can throw the heart into fatal ventricular fibrillation.
Oh, wow. It's a terrifying margin of error.
He really is.
And medical emergencies don't always look like a Hollywood heart attack. Take case 22, hypoglycemia in a diabetic patient.
Such a tricky one to spot initially.
Exactly, because the brain relies almost exclusively on continuous glucose to function. When that glucose drops, the patient doesn't necessarily just pass out.
Right, the primary sign might be localized entirely in their behavior.
Yeah, sudden confusion, uncharacteristic aggression, or a glassy-eyed loss of focus. They might just seem profoundly uncooperative out of nowhere.
What's fascinating here is how the cognitive architecture of problem solving helps clinicians avoid fatal biases in these panic-inducing moments.
Also,
Well, when a patient starts acting aggressively, the availability bias might make you think they are simply an uncooperative patient or perhaps experiencing a psychiatric episode.
aye.
But Odell's structured framework forces you to evaluate systemic causes first.
I have to challenge the reality of these frameworks, though. Odell presents a terrifying scenario involving a dropped instrument, ominously titled A Tooth Lost at Tea Time.
Oh, case 23, a nightmare scenario.
When a patient actually starts choking on an endodontic file or a slippery premolar, the physiological freeze response in the clinician is overwhelming. How does a structured problem-solving model actually prevent a clinician from just freezing up? And what is the exact immediate management versus long-term follow-up for aspiration?
That's a great question. The freeze response happens because the prefrontal cortex, the logical part of your brain, gets totally hijacked by the amygdala during a crisis.
You just go blank.
Right. So a rigid, rehearsed algorithm bypasses the need for high-level decision-making. You don't have to formulate a plan, you just execute the pre-programmed steps. Airway, breathing, circulation.
Okay, so what's the immediate management?
For active choking, immediate management is mechanical. Encouraging coughing, delivering back blows, and abdominal thrusts to force residual lung air up the trachea to dislodge the object.
But let's say the coughing stops. The patient is breathing normally again, but the tooth is simply gone. You can't see it anywhere in the oral cavity. We can't just assume they swallowed it into the GI tract, right?
No, absolutely not. Relying on the assumption that they swallowed it is a classic example of premature closure stopping the diagnostic process just because you found a convenient answer.
So what's the long-term follow-up then?
A suspected aspiration requires an urgent referral to the emergency department for a chest radiograph. If that tooth bypassed the vocal cords, the anatomy of the human respiratory system means it almost always lodges in the right main bronchus.
Because it's wider and more vertical.
Exactly. It's wider, shorter, and takes a more vertical angle than the left. If left in the lung, the bacteria-laden plaque on that tooth will inevitably cause a localized lung abscess, necrosis of the surrounding tissue, or massive, potentially fatal aspiration pneumonia.
Wow. In those moments, losing control of the clinical environment is just so sudden.
It's instant.
But let's look at a different type of control. From managing acute systemic crises, we move to chronic, specialized patient management. If emergencies test our reflexes, special needs dentistry tests our adaptability and empathy.
Beautifully said.
In special needs dentistry, we often treat patients who arrive already feeling a total, terrifying loss of control over their sensory environment. This requires a massive shift in how we approach care.
Odell covers this really well in Case 42, scenarios involving severe autism and epilepsy.
Yeah, will you see my son?
Exactly. Treating a non-communicative patient is profound detective work. If the patient is clearly in distress or pain, but cannot articulate where or why, you have to systematically rule out the hidden culprits.
And caries is a massive risk factor here.
Huge. But you have to understand the why behind it. Often, caregivers use high-sugar treats as behavioral reinforcers just to get through daily routines.
Right, and if we factor in the epilepsy, you have a patient prone to sudden violent falls. The pain might not be a cavity at all.
It could be trauma.
Yeah, we have to suspect trauma, specifically a non-vital, abscessed, deciduous incisor from a fall they had months ago that no one witnessed.
You also have to assess for self-mutilation. Some patients might repeatedly pick at their gingivae or buccal mucosa as a self-soothing mechanism, causing severe, painful ulcerations.
Oh, that's tough to manage.
It is. And you can never forget the normal physiological milestones that cause discomfort. A child might be having a meltdown simply because their lower primary incisors are naturally exfoliating and highly mobile, or they are experiencing painful pericoronitis from erupting first permanent molars.
I always think of the traditional dental environment as a sensory overload trap.
That's a great analogy.
Thanks. I mean, from the patient's perspective, we throw them under landing overhead lights, blast the high-pitched, unpredictable whine of a high-speed handpiece, flood the air with the sharp chemical smell of acrylics and eugenol.
And then a masked stranger invades their personal space.
Exactly. For a patient with severe autism, we have to dismantle that trap piece by piece. We keep the chair stationary so they don't feel a loss of gravity. We use tactile toys to ground them, and we kill the overhead lights entirely until the absolute last second.
And this brings up the incredibly delicate reality of physical contact and behavior management.
Yeah, the medico-legal aspect.
Right. The literature acknowledges that the medico-legal landscape has made many clinicians, particularly male dentists, deeply uncomfortable utilizing physical touch for reassurance due to the fear of misinterpretation or accusation.
It's a very real anxiety for practitioners.
It is. But a physical touch or a gentle guiding hand is absolutely clinically necessary to prevent the patient from sudden movement and injury. The boundaries are rigid.
What are the strict rules there?
Touch must be strictly limited to the head, shoulders, and hands. And absolutely, unequivocally, always with a chaperone or caregiver present in the room.
No exceptions.
None. Furthermore, your clinical notes must be contemporaneous, meaning written immediately after the appointment, and comprehensively detail exactly what behavior management techniques were used and why.
Okay, so we've managed the systemic emergencies, and we've adapted our environment for profound behavioral challenges. Now, we finally zoom in on the actual tissues.
Right, moving from the whole patient to the local pathology.
Exactly. We transition from observing the patient's actions to interpreting physical and radiographic signs. Let's look at Odell's exploration of multilocular radiolucencies, like in case 2.
When you look at an OPG radiograph and see that classic soap bubble or honeycomb appearance expanding the jaw, your differential diagnosis has to snap to a few key biological players.
Like ameloblastomas.
Yes, ameloblastomas, odontogenic keratocysts, or OKCs, and central giant cell granulomas.
Wait, with multilocular radiolucencies, if they all look like soap bubbles on an X-ray, what is the specific radiographic tipping point that makes you say, this is an ameloblastoma and not a keratocyst?
The distinction lies in how the cells behave. An odontogenic keratocyst develops from remnants of the dental lamina. It primarily expands via osmotic pressure within the cyst lumen.
So it's pressure-driven.
Yes, and because of this, it tends to take the path of least resistance. It grows anteroposteriorly, tunneling along the medullary cavity of the jawbone, often reaching a massive size before it causes any noticeable buccolingual expansion of the cortical plates.
So it weaves through the hollow spaces of the bone.
Precisely. An ameloblastoma, however, is a true benign neoplasm of odontogenic epithelium. It is locally aggressive and driven by cellular proliferation, not just fluid pressure.
So it doesn't care about the path of least resistance.
Not at all. It expands outward forcefully, ballooning the cortical plates. And crucially, because of this aggressive expansile pressure, an ameloblastoma is highly prone to causing severe knife-edge root resorption of the adjacent teeth.
That's the tipping point.
Exactly. If you see massive outward expansion and the roots of the nearby molars look like they've been sheared off, ameloblastoma jumps to the top of your differential.
And this is exactly why the standard of care has shifted away from relying purely on 2D panoramic films. For these lesions, Odell and the ADC guidelines highlight the mandatory role of CBCT.
Cone beam computed tomography. It's essential.
Right, because a 2D film flattens a 3D structure. You can't see the true extent of cortical perforation or where the lesion sits in relation to the inferior alveolar nerve canal. That 3D spatial awareness is non-negotiable for surgical planning. If a surgeon attempts an enucleation or a marginal resection without knowing the exact millimeter distance to that nerve, they risk severing it, leaving the patient with permanent lip and chin paresthesia.
Which is devastating.
Yeah.
Now, moving from the hard tissue of the jaw to the soft tissues of the mucosa, we encounter an entirely different kind of high-stakes diagnostic challenge.
Yes. Cases 45, 46, and 57.
Right. Odell presents cases involving white patches on the tongue and the terrifying reality of oral cancer.
Soft tissue pathology requires you to distinguish between common, reactive, benign findings like frictional keratosis from a sharp tooth, or an autoimmune condition like lichen planus, and serious, potentially fatal malignant pathologies like squamous cell carcinoma.
And the foundational concept here is cellular dysplasia, right?
Exactly. Dysplasia is abnormal cell growth and maturation. It is the insidious precursor to invasive malignancy. This raises an important question regarding clinical judgment. As a general practitioner, how do we confidently determine when to simply monitor a lesion in general practice versus when to urgently refer them to a maxillofacial specialist?
Yeah, when you hit the panic button.
You base that decision on specific, aggressive clinical hallmarks. We employ the strict 2-week rule.
The 2-week rule, how does that work?
Well, if you identify a potential traumatic cause, say a fractured amalgam cusp rubbing the lateral border of the tongue, you smooth it down. If the lesion is still there 2 weeks later, the monitoring phase is over.
You don't just keep waiting.
No. You also look for induration. If a white or red patch feels hard, firm, or tethered to the underlying muscle, that is a massive red flag.
Because it means it's invaded deeper.
Exactly. It implies tumor cells may have infiltrated through the basement membrane. Add in rolled margins or a lesion that bleeds upon gentle palpation, and you immediately refer for an incisional brush biopsy. The cognitive architecture here isn't necessarily about you confirming it's cancer. It's about recognizing the limits of primary care and moving fast enough to save a life.
That makes total sense. And pathology, whether it's a massive cyst or an unrestorable tooth, inevitably dictates surgical intervention. But surgery inherently carries the risk of complications.
It always damages tissue.
Right. We now bridge our clinical interventions with postoperative management and patient communication. This ties directly into the ADC communication scenarios. Let's start with case 15, the most classic post-surgical complication we see, alveolar osteitis.
Dry socket. It's a fascinating, highly painful phenomenon. The patient typically returns to your clinic 3 to 5 days post-extraction.
And they're usually in agony.
Severe, deep, throbbing pain that radiates up the side of their face. There's a foul odor. And when you look into the socket, it's empty. The blood clot isn't infected. It has just undergone premature fibrinolysis.
So the clot physically dissolves before the granulation tissue can even form.
Yes, leaving the raw bone and the terminal nerve endings completely exposed to the oral environment, air, and food debris.
The ADC communication protocol for this is very rigid because patients are often angry. You have to clinically validate their pain. You gently irrigate the socket with warm saline to flush out the necrotic debris.
Never scrape it.
Right, no scraping. And then you apply a specialized medicated dressing, often containing eugenol, to physically cover the bone and attune the exposed nerve endings. But a dry socket is relatively simple compared to anatomical breaches, like an oroantral fistula, which is case 18.
Right. An oroantral fistula represents an unnatural epithelialized communication between the oral cavity and the maxillary sinus.
Because the roots are so close.
Exactly. The roots of the upper first and second molars often intimately drape into the floor of the maxillary sinus. When you extract one of those teeth, the thin bone can fracture, tearing the sinus lining.
So how do you test for it in the chair?
You might ask the patient to gently pinch their nose and blow the Valsalva maneuver, and you'll actually see air bubbling through the extraction socket.
The immediate management is all about preventing chronic sinusitis. You encourage a strong blood clot, often using figure-of-8 suturing, and prescribe antibiotics and nasal decongestants.
To keep the sinus clear and the pressure low.
Right. But if it doesn't close and becomes a chronic fistula, the patient will complain of fluids going from their mouth out their nose when they drink.
That requires advanced surgical closure.
Like a buccal advancement flap.
Usually, yes. The surgeon essentially takes a broad-based flap of the cheek tissue, scores the inelastic periosteum underneath to allow it to stretch, and pulls it entirely over the bony defect to create a watertight seal.
But the critical part of the ADC framework is that you have to communicate the risk of that sinus exposure before you ever pick up the forceps.
Managing patient expectations is the core of modern practice.
Exactly. Whether it's explaining that a tooth with a deep vertical root fracture, a VRF, cannot be saved with a simple filling, or managing expectations around an amalgam replacement or a cracked cusp.
That is the essence of the duty of candor, which Odell emphasizes in cases 30 and 71, dealing with patient complaints and clinical errors.
So what does this all mean? Summarizing this up, it means that your technical excellence, your perfect margins, and your flawless suturing is utterly useless without transparent, empathetic communication.
It really is.
The duty of candor is the absolute legal and ethical obligation to be completely honest with the patient when an error occurs. You don't hide the broken file in the canal.
No, never.
You explain what happened, you offer a sincere apology, and you outline the exact steps to manage it, all while keeping meticulous, contemporaneous records. And when you are offering treatment options like an extraction versus an expensive specialist referral, it requires impartial, clear consent without pressure.
If we pull back and look at the biological big picture, The duty of candor is more than just a legal shield to prevent lawsuits. It is fundamentally a clinical tool.
Also,
Honesty builds trust. When a patient genuinely trusts their clinician, their psychological anxiety drops. That drop in anxiety lowers their systemic cortisol levels, which reduces sympathetic nervous system activation.
the fight or flight response.
Exactly. Lower sympathetic tone improves peripheral blood flow and optimizes the immune response. Establishing profound trust quite literally improves a patient's compliance and physiological healing during complex post-operative recovery. Candor makes you a vastly better healer.
Wow, I love that perspective. Trust as a measurable physiological healing agent.
It changes everything.
It really does. So to briefly recap the incredible clinical journey we've taken today, we've explored mastering the differential diagnosis of sudden collapse. We've looked at the intense empathy and adapting environments required for our special needs patients.
We differentiated the biological growth patterns of massive jaw radiolucencies.
Right. Understanding why an amelblastoma requires a vastly different surgical approach than a simple cyst. And finally, we've unpacked communicating transparently during surgical complications.
It continually comes back to trusting the cognitive architecture of clinical problem solving. It is about actively removing our human biases, rigorously following the established diagnostic frameworks, and remembering to treat the entire complex human being sitting in the chair.
Not just the isolated two.
Exactly.
Couldn't agree more. And I want to leave you, the listener, with a final provocative thought, drawing from the new material introduced in the 5th edition of Odell's. We've spent this entire deep dive unpacking human cognitive biases and how we use frameworks to overcome them. But looking forward, how will the rapid integration of advanced AI-assisted intelligence and CAD/CAM technology fundamentally alter this cognitive architecture?
That's the million-dollar question.
Exactly. When an AI system can instantly, with near-perfect accuracy, differentiate an early-stage ameloblastoma from a keratosis on a CBCT scan, or perfectly predict a patient's risk of a dry socket based on their systemic data, the purely diagnostic burden will lift.
It's going to change the profession.
In that coming decade, your primary role as a clinician will shift drastically. It will move away from pure data analysis and push you almost entirely toward profound human empathy, complex surgical execution, and the irreplaceable art of building trust. For more dental examination prep tips and clinical deep dives, please subscribe and share this episode.